We have done about 300 cases. 10 to 15 years follow-up, no TKR was done. Good to excellent, 72% result. TKR less than 5 years, none. TKR more than 5 to 10 years, only in 10 cases of 300, that is 0.3%. And TKR between 10 to 15 years after high tibial osteotomy in 40 patients, that is about 12% cases. My boss, Dr. Dholakia, used to say, although HTO has become secondary to uni-compartmental orthoplasty in the Western world, but it will remain in this part of the world because our population doesn't want orthoplasty. Instead of that, they are ready with high tibial osteotomy very easily. And you can see here 15 years follow-up X-ray with 7 degrees valgus deformity still maintained in this particular case. Thank you very much.
Thank you, sir, for your nice presentation. Any question to Professor Junjunwala?
Sir, what type of osteotomy we should select? It is Mackay or conventry? Like you have shown both of the osteotomy.
I do above tibial tubercle osteotomy. Not below, supratubercle.
Supratubercle.
Yeah, where the healing is faster, easy, less painful. Below the tibial tubercle, you cannot say 100% it will unite in 4 months' time. In one of my case, it has united in 6 months. The patient was eating my head that why the osteotomy is not healing.
Sir, the upper segment is very small. Can we fix comfortably with the illizarov?
Sorry?
The upper segment, if you do a high osteotomy, like it is very near to the joint.
Sorry, I could not get your point.
Sir, when you are doing osteotomy, supratubercle osteotomy, can you put it with illizarov?
Yes.
Because the segment is very small.
Yes, I have shown you the above supratubercle osteotomy. In young patient, the bone is quite good where you can put wires.
Okay.
You put 2 or 3 wires at the tibial tuber, at the tibial condyle, and that much space is there. Okay. It is about 1.5 centimeter space through which you can put 3 wires and you can put 1 ring, and that is quite enough to hold and stabilize the osteotomy.
Thank you, sir.
Doctor, after all this discussion, what do you suggest? HTO with Tomofix or Indian plate, or HTO with illizarov, and either domostomy or oblique osteotomy? What is your choice, sir?
Some people don't like illizarov. The rings and all, they cannot tolerate for a long time. So those where there is about 12 degrees varus, I do with the commentary staple so that the wound heals up very well and patient can walk faster with the plaster for about 4 weeks. After plaster is removed, the patient can walk still very well. But where there is a possibility of very lateral ligament laxity, if you do commentary staple, it will go again into laxity because the lateral ligament will stretch more and more. And therefore, the tightening of the lateral ligament by pulling the fibula down is always a good method.
This is not commentary. We are saying choice between domostomy or oblique osteotomy.
I don't do oblique osteotomy. I do only transverse osteotomy, closed wedge osteotomy, and lateral ligament laxity. I pull the fibula down.
Sir, one question. Yes, sir, there is some confusion. The same type of degeneration, type 2 or type 3, if you subject the patients and randomize and subject the patient to TKR, unicondylar and HTO, well done, all. Everyone claims that the results are good. But what is the common thing, how the results are good in 3 different types of surgeries? What is the common principle which we are doing or dealing in these cases?
See, the TKR results will last for 10 to 12 years. High tibial osteotomy results are much longer. and they will last for longer. Even people get after 15 years slight pain they can pull on with the valgus osteotomy. Unicondylar results are also now shown that after 10 years the unicondylar knee fails. So it is the high tibial osteotomy which gives a better long-term result.
Sir, does STO improves
Just
patellofemoral?
speak in the mic so I can hear.
Sir, does STO improves patellofemoral pain, patellofemoral joint pain after STO improves or not?
No, they don't get patellofemoral pain because it gives a slight Mackay effect. The tibia is slightly translated anteriorly, and therefore the patellar ligament gets laxed. Thereby, patella changes its own position and doesn't rub on the same place where it was rubbing.
So it improves.
So the change of patellofemoral joint doesn't cause any pain.
And last question, sir.
Very nice paper. Sir, I have a query. In one of the case you have shown that there is depressed fracture of medial tibial plate 2 and you had applied a staple. What is the idea? Do you elevate the depressed or what to do?
I'm sorry, I could not get your question.
In one of the case, there you have applied this staple and there is a medial tibial plate 2 depression. Depression over the medial tibial plate 2, there is depressed fracture. Is it so?
Sorry,
Yeah, you discuss this later on with sir. Okay, sir,
I'll
you
talk
continue.
later, yeah.
So, you continue the next lecture, sir. Now, Professor Junjunola, sir, is going to talk on role of limb reconstruction system, LRS. I will take a lunch, okay, I just, okay.
नहीं ये तो मेरा निकालना.
Sit. Better camera, no, you finish this. Better you will be, close this. Better I have that one, but pen drive, that is memory card, only left 3 or 4. Or you can put that one there.
This also doesn't clear, same like.
Why it not comes? Who told you? It must be. Maybe here. So it must be. This is record. This is, why not come?
It's not very clear.
Clear. It will be clear. I will put in my camera that one. It will be clear. Take. Again. Oh, why not clear? Everything I will put there.
5, sometimes less, sometimes more. Yes, you need to replace this implant for another. And now we get a very big group for osteomyelitis and problems with implants. So we have another direction in Lizarov technique is working with implants, with the septic implants. So in our septic department we have a lot of patients with septic conditions and implants. So it's another point of view.
So I think
we will continue.
if there is a protocol which comes from your institute, that according to this age, according to this grade, according to this much of deformity, this is the surgery that is required. A good classification can come out where you can probably tell and predict that, okay, this is the age, this is the thing, and this is the treatment.
So
it should
really
be
we
useful for all of us.
Really, we have the same problem as in the whole world. Is the big pressure within this industry and very active work of joint replacement departments. So, absolutely.
Thank you.
Can I start?
Yes, sir. Yes, you start.
I'm going to talk about what are the indications for illizarov. There are mostly same indications for the using limb reconstruction system of orthofix. That is what we call as LRS. Indications are limb lengthening, open fractures. In open fracture, it is used as a external fixator, infected non-unions, severely cubinated closed fractures, juxta-articular fractures, and for arthrodesis or osteotomies. It is an ideal external fixator, showing it gives a very good stability. It is a simple fixator, adjustable geometry, comprehensive, lightweight, inexpensive, and easy to handle, and patients friendly. This is a LRS fixator which shows a rail. Over that these are the compartments over the rail which moves from up and down or up and down here. This is the another tray or compartment where you can put little oblique screws possible, and this is the tapered shank screw. So this is a tapered. Once it goes to the distal cortex of the bone, you should not remove it back. If you remove it back, it will get loosened out, because this is a thinner portion, this is a thicker portion, and because that it holds very strongly in both the cortices. We have used LRS for 50 patients over last 2 years in the Bombay hospital. Males 40, females 10, infected cases 36, and non-infected cases 14. We used LRS in 22 cases of femur, 26 cases of tibia, and 2 cases of humerus. Non-infected cases 14, infected cases 36. 6 ratio. Bone in which LRS was used was femur 22, tibia 26, and humerus 2. Indications of use of LRS in our series was arthrodesis of the joint in 3 cases to achieve compression and stability at the fracture site, 31 cases, and limb lengthening, 4 cases. For stabilization of fracture and bone transportation after corticotomy in cases of infected non-unions with bone loss, in bone transportation in 12, lengthening in 4, arthrodesis 3, stabilization and compression in 31 cases. Case study, this is the first case, 13-year female with compound grade 3C fractured tibia fibula with neurovascular insufficiency. After vascular repair and multiple debridement, plating was done outside. This was the plate, and it got infected. Gap non-union, scars, multiple sinuses, plate exposed, and sensory deficit. Bone grafting plus distal corticotomy. Bone grafting is done. Fixation with the LRS. Distal corticotomy was done. And transportation is done of this middle fragment up to here, and this is the bone transport, and this is the final picture with good union of the tibia and no infection. Another case, fracture shaft femur with fractured patella. Patella was operated by tension band wiring, and the surgeon who did interlocking nail did not see the combination of the femur, and therefore there was 3 centimeter overriding, and he had 3 centimeter of the shortening. So what he came with 3 centimeter of shortening. So what I did, overriding of the fragments and shortening of the bone. This was after 3 months the patient came. After 6 months of the interlocking nail, the fracture did not unite. And therefore, what I did, I put a LRS along with the femur nail and slowly distracted to get 3 centimeter shortening. and which was easily, you can see on the femur. And after 1 year, 2 months post-operatively, the osteotomy has healed up very well. No, I have not done any osteotomy. I just distracted the fracture, and it healed up after 20 months. And for 20 months, LRS was stable. That is most important. Another case, this was a fracture lower 1/4 of the tibia fibula with partial bone loss. Operated in other hospital with interlocking nail. Patient was walking about. After 3 months nailing, there was no healing. So 2 months after dynamization, they did dynamization. The upper screw was removed. Patient was walking. After 9 months, no healing, so they did bone grafting. So at this stage, the patient presented with us with persistent non-union after 1.5 years, despite all measures taken for bone union. That is, bone grafting was done, dynamization was done, interlocking nail was done properly first time. So with 1.5 years non-union, we have removed the excision of the lower end of tibial fracture, which was sclerosed, and a osteotomy has been done at the higher level to transport the most of the tibia down, and this is the LRS fixator which was fixed on the patient itself. Patient could move his knee, and bone transportation with proximal corticotomy was done. You can see here, corticotomy. Union achieved and limb length restored in 1 year. Another case, arthrodesis of the knee with LRS, which was very good compression you can get, and the arthrodesis also heals up in 2 months' time. If you want to do a old septic arthritis of the knee, and this was the arthrodesis of the knee was done. Another case of 43-year female with subtalar arthritis secondary to malunited calcaneal fracture, subtalar fusion achieved with LRS plus autograft. This was the LRS fixed, and I give about 1 millimeter more compression after 8 days, so that whatever the compression resolves the bone, you can still compress later on, and you can do this, and patient could walk about with the for the arthrodesis of the knee subtalar joint.
Now I will speak. You remember my lecture?
This is a long-standing infected non-union used as a compression device. Here, the non-union, just a LRS was fixed and used as a compression. You can do compression with this compression assembly, and you can get, because it was a hypertrophic non-union, you could get union very fast. This was the recalcitrant gap non-union in a childhood chronic osteomyelitis femur, and they have put plate which was broken and non-union. So I have removed all, debrided, cut this bone here transversely, cut this bone here transversely, then put LRS, and compression was achieved with the LRS, and bone grafting was done, and the fracture healed up. Infected non-union, corticotomy, and bone transportation. Again, this was infected, so removed all debridement and removed the infected portion of the tibia. LRS was put, and transportation was done, and fracture healed up. 9 months old follow fracture united. Problems with LRS, that pin loosening. If you take the pin back after putting, the pin gets loosened out, pin tract infection, bending of the pins at the pin-bone interface. It is a monolateral fixator, so you cannot give 100% weight while walking. You can give partial weight with the crutches or with the walker. It has a limited span of pin placement zone because the screw has to go through that particular hole of the compartment of the LRS. So LRS is highly stable, rigid, but lightweight, simple to use, comprehensive, inexpensive, easy to handle, and patients-friendly external fixator with a wide range of application. Thank you very much.
Now I invite questions. Any questions to Professor Junjunwala? No question.
Wonderful.
Then I am the last speaker.
So Dr. Bari is going to speak. Dr. Bari has come from the Bangladesh. He is doing the pioneer of the.
Excuse me, sir. One question. What was the shortening in fracture, infected non-union subtrochanteric fracture that you showed with a large gap?
Last time it was.
Was you able to restore the limb length?
I think it is 3 centimeter shortening there.
So one more thing. In the first case that you showed, you did bone grafting and bone transportation.
Yes.
Isn't the bone graft that you put, that they interfered in the bone transportation part?
That was my first case. I thought it is a very big gap, and therefore I put cancellous bone, which after transportation, which has given a good callus formation. But it is not very necessary to put bone grafts.
Thank you, sir.
Yeah. Dr. Bari, he is the professional HOD of the medical college. He has got PhD awarded by the Kurgan Institute. And he is the pioneer. He has written books also. So we invite Dr. Bari.
Chairman sir, my dear colleagues, dear Indian friends, I have lot of Indian illizarov surgeons, those who I know them very well. They are sitting here because I am working for the long time. I am doing illizarov surgery as well as other surgeries also. But I am very much fond of this illizarov because I finished my graduation from Kiev, capital of Ukraine. Then I did my PhD from Tashkent, capital of Uzbekistan. And I did my 3 times post-graduation from Kurgan. And last year, they have honored me as the honorary professor of the Kurgan Illizarov Center. And I am very much grateful to Dr. Agarwal and Manish Dhawan. Last 2 days, that is first and second, we had a very good time in Delhi, and I presented there in osteomyelitis and very difficult cases that was treated by illizarov. Today, I'd like to talk only in the upper extremity, IULR, illizarov in upper limb reconstruction. Illizarov in upper limb reconstruction. So this is my institute that is next to Kurgan, 500-bedded hospital, which is situated in Dhaka, capital of Bangladesh. These are the old faculties. I am in charge of the illizarov reconstructive surgery unit. This is the Kurgan Center, very beautifully built. You see, if you look at it from the top, this is a fantastic one, which is now the 1,000-bedded hospital, the largest hospital so far in the world. And upper limb reconstruction in different diseases is a good choice for treatment. See, this is the illizarov Center workshop. And aims of IULR, aesthetically beautiful functional arm, forearm and hand,
correct shortening and deformities. Biological reconstruction is the cornerstone and normalizes anatomical axes. You know, these are the all indications you can do by correct by Illizarov. Now I would like to talk on you the diseases concerned. Let us see some cases. GCT, head of the humerus, distal radius, acute trauma, open fractures, fracture dislocation of the elbow, lengthening of the arm and forearm, A50 elbow, pterygium of the elbow, non-union of the humerus, radius and ulna, cubitus varus and valgus, osteomyelitis of the humerus, radius and ulna, infected non-union of the radius and ulna, big gap non-union of the radius, serpentine deformities of the forearm, proximal migration of the dislocated radius with ulnar shortening, the post-burn contraction of the wrist and fingers as well as macrodactyly also. Why Illizarov? I always tell my residents, if you look at the name of the Illizarov, I, that means you must have intelligent and you can do a lot of innovative things. This is number one, I. L, you can go for lengthening. Again I, you can control the infection. And Z, you can correct the deformities, that is zigzag. And A, adaptable. R, reliable. O, you have got lot of opportunities, or okay. And of course the last one is the V, versatile. So, if you ask you something, what is Illizarov? You can say like this. So advantages all of you know. Disadvantage, of course, greater learning curve, and the apparatus is of course the bulky. And post-operative care is very important. This is the key to success. Now let us see some cases. A young girl of 18 years with GCT, head of the humerus. First time intervention was done elsewhere outside the Dhaka. Then she came to our institute. What we have done? We have removed the most of the part of the head of the humerus. Only a part is remained. Then we did the corticotomy in the middle of the humerus. Bone transportation was done. Now you see after 7 months follow-up. And this is after 1.5 year follow-up. Let us see the G of the distal radius, 30 years old man. Of course, there are a lot of options, but you can do correction with the Illizarov apparatus. First post-op, this is after 5 months follow-up. This is before, after 1 year follow-up. Of course, there is some restriction of the movement in the wrist and hypertrophic non-union of the humerus. There is a massive callus here. You don't need to open. Only you I put the two shunts up, one ring here with the arch, give the distraction. 6 years old boy. Now you look. This is the how regenerate of the bone. Final follow-up only after 3 months. So young child of 6 years. This is post-traumatic, in fact, LLD, 18 years old girl. Bifocal corticotomy was done. Oh, I've lost that one. This is C, another one. Big gap non-union with bad scar, stiff elbow, disused osteoporosis. No other options in the world so far, I think so. You can correct all these problems with this simple Illizarov apparatus. Now look at this after 3 months follow-up, and this is the final follow-up after 5 months. Bone was so osteoporotic and there was a bad scar, you could not go open surgery. The Marcher told in 1990, the decision is more important than the incision. So let us see the pterygium, some cases involving the elbow, waving of the elbow. This is before, after, this is after 4 months. Sorry, I could not run the video here. 9 years old cubitus varus, you can do cubitus varus correction at any age. Mode of introduction of the verse, simple opening wedge, and this is the before and only after 2 months. Cubitus varus, although there is no problem, only cosmetical problem, so you can correct that one. Now see 3 months old dislocated right elbow of a 27 years old man, what to do? After reduction with illizarov, gradual passive range of movements, using rods in the stiffness. My video is not running this. These are the other cases of 36 years old man, neglected dislocated elbow, see before and after, before and after. And in summary, if elbow is unstable after fixation of the associated fracture and the repair of the lateral collateral ligament, illizarov hinged external fixator provides satisfactory results. Now let us see the proximal migration of the left radial head with shortening and deformed ulna. Age 11 years. What to do? Look at this right side, final follow-up after 6 months. Now this is a case was a post-traumatic, very big gap non-union of the left radius with uniaxial external fixator. He came to me after 3 months. Then bone transportation. This is before and this is after 1 year follow-up. Serpentine deformities of the right forearm with shortening of the 14 years old boy. You cannot do anything. This is the absolute indication for illizarov. With any other options, if you want to lengthen, if you want to correct the deformities, you should have to go for illizarov. 2 months post-op, 4 months post-op, before, after 6 months follow-up. Post-burn contracture of the wrist with MCP joint, 13 years old girl. illizarov, before and after. And finally, dear friends, see this macrodactyly of 25 years old beautiful lady. Debulking of the soft tissue was done and shortening of the proximal phalanx with mini illizarov apparatus. And this was before, and this is after 5 months follow-up. Now you see the fundamental principle of the illizarov methodology is load and motion. See what they are doing in the Kurgan center. This must be, it was that. So look. It was running at the time. This one video. Yes. So look. So illizarov in the hand, in the lower limbs, what they are doing, by putting the illizarov, you shall have to tell your patient the full weight bearing. You must do it. He is playing badminton. So look, or what we are doing in the third world countries, put the illizarov, doing nothing. See, he has taken dumbbell with his right hand, doing exercises. And this is the rehabilitation center in illizarov center, Kurgan. See, look, what the instructors are doing. Okay, so, and next. Of course, complication, you know, and illizarov method is not hard to learn, but it does take proper knowledge, effort, devotion, patience, practice, and intelligent, meticulous follow-up from time to time. If you really want to do justice to your patient, you should opt for it. And in my conclusion, a scientific and practical breakthrough in the 20th century, our task is to promote it. Illizarov will restore the harmony of your body and soul. Now, how we can get peace? Do you know what is peace? Perfect endeavor around the countries of the world or the earth. Or you can get peace by doing a fruit of silence is prayer. The fruit of prayer is faith. Fruit of faith is love. Fruit of love is service. And by giving service, you can get peace. Thank you very much.
Thank you very much. Any question? Only one or two questions. And then we'll go for lunch.
Sir, do you treat...
And after lunch, come at 2 o'clock to start the next session. Because we have a lot of
Can you start? क्यों अभी 5 मिनट वेट करें? 5 minutes.
I have to inform outside.
Yeah, जरा बोल दीजिए, क्लैपिंग करके बोल.
So can we kindly ask you to vote or maybe to make some proposals about our questions? So it's not only about spine or X-fixed spine. We are talking about illizarov and orthopedics in whole. So now we are making big changes in our rehabilitation system. And Dr. Barry showed you some movies from Illizarov Center and stressed your attention on a very good rehabilitation. So it's very important. So can you tell us, do you have in your clinic a special department for rehabilitation? Vote, please. Who have the special department for rehabilitation? Separate department for rehabilitation. Who have? 1, 2. Dmitry Yuryevich, can you count, please? How many? Number 1, how many? Yeah. Or Sergey, can you please write it? Write it. So how many? Only 3? Only 3 hospitals have separate department. 4 departments have separate department for rehabilitation. Department with physiotherapists, yes? Okay. 4 hospitals. And how many hospitals are here? How many hospitals, how many participants are from different hospitals? How many hospitals? Show your hands, please. How many? So all of you are from different hospitals? From different. So how many participants? Please count. So about 25 now here, about 25 participants. So only 4 have a special separate department for rehabilitation. Okay, but do you have in your hospital special people who are not in a separate department, but maybe they are in your departments, in your ordinary surgery orthopedics departments, who helps you to make rehabilitation? Maybe special nurses or physiotherapists. Do you have these people? Vote, please. So all hospitals, not all. Who doesn't have? Who doesn't have? What hospitals doesn't have this specialist at all? So all hospitals have this specialist, yeah? All hospitals, okay. And then what kinds of physiotherapy do you use? Is it usually training special training for patients? Vote. Okay, special training when they try to get more movements, special training, okay. Some special electrostimulation. Electrostimulation, how many? Okay. Electrophoresis? No? One, okay. Oxygen therapy? Oxygen therapy. Do you know what it is? No? Hyperbaric therapy. If anybody have? No? Massage? Massage. Who has? 4? 5? 5. Massage? Yeah. And your opinion, it's very important. What is most effective? What is most effective? So we were talking about electrostimulation, about massage, about training. What is really effective? Training. So really, do you see any evidence in electrostimulation, in massage, or no evidence?
Massage only for passive edema resolution.
Okay. Initially, okay. Only for this. So you have strict indications for this. So in what hospitals do you use special protocol for physiotherapy? Who have special protocols? One. Only one hospital has special protocols for physiotherapy. 2, okay. And in other hospitals, how do you work with the physiotherapists? So you usually ask them, especially for some patient, to help, or what are you doing? No protocols. Okay, and how many specialists are involved in physiotherapy? So less than 5. In what hospitals? Less than 5. Okay, how many you have? How many? 4. Okay, it's nurses or they are doctors? Doctors. And nurses? No?
They are technicians.
Technicians. And they are using, do you use orthosis? Orthosis? So they are together, do orthosis and physiotherapy, yeah? Together. So you have a special orthosis department or no?
Yes, but only done by technicians.
Technicians. So some technicians making orthosis, and with physiotherapists they are make some training and orthosis, yeah? Use orthosis. Okay. And who have more than 5? You? More than 5. How many? 6. Okay. So we have about 70, if I'm not mistaken. Yeah? Or more. 70, yeah. So we're thinking about this. 70 with nurses and doctors, maybe 70 or 80 in our staff. And we have all these we mentioned above. So we have hyper oxygen therapy, a lot of massage, a lot of electrostimulation, different kinds of, a lot of massage, a lot of training, but not enough. Not enough. So what is your opinion? Is it very important to have separate department? Who are for separate department? You are for separate department. Or to introduce all these people directly to departments, directly to the bed of a patient, to work together with surgeons in a big team. Who are for this decision? Who? Vote please. You, only one. So you don't have any opinion about this. So you are not involved in this process really, or you involved in the process of rehabilitation. Who usually make the decision to use physiotherapy in your hospital? Who do this? Surgeon, yeah, surgeon. So surgeon said that here is it's okay, electrostimulation or yeah. So surgeon do this, not doctor.
Not the specific treatment. If they don't know, if it's new to them, then we explain. But otherwise, by now they're trained.
So it's like protocol. It's usual protocol. They usually do this. Okay. Thank you very much. It's very important for us because it's a big challenge. What to do next? How to improve our system of rehabilitation because it's so huge, and we need some new decisions. And it was important to know because in Illizarov method, rehabilitation training, especially, is very, very important. Absolutely important. Yeah.
So please can you tell us what's the role of hyperbaric oxygen therapy in Illizarov?
The rules.
Yes.
Can I tell you to your ear, not to the whole? Please, because it's a big challenge really, and a big problem, because we use it not mostly for Ilizarov techniques. It's impossible to use it for Ilizarov technique. We use it for another indications really, not for Ilizarov. Okay, let's speak a little bit about external fixation in spine surgery. And frankly speaking, it's a very challenging task because most of the people really don't use it in spine surgery widely. And of course, we are from Illizarov Center. Of course, we have our own opinion and our own approach for using X-Fix. But this approach was dramatically changed in the last 2-3 years. So now we got very strict indications for using X-Fix in spine surgery. We have a big department of neurosurgery and spine surgery, mostly spine surgery. It's about 70 beds. And we made usually about 1,000 procedures, spine operations per year. So a lot of, in all fields, from children, very little children, several months, to very old people. So all ages and all pathologies. Besides, we have some beds in septic department for some septic conditions of spine patients. So the plan is very short. Is it useful at all? X-Fix. I will tell you about types of spinal external fixation and some examples how we can use it.
Like MBA administrator.
So is it useful? Most of the spine surgeons don't use external fixation at all. Some deny it. We not. Some use it as a temporary traction or fixation stage in deformities and back pain surgery. Some people try to make it as only one method, but unfortunately it's impossible. But of course, external fixation can be excellent in some fields. So for low back pain problems, because Mr. Agrawal will tell us some more information about this, they have their own clinical experience. We don't have our clinical experience in Illizarov Center because we used external fixation only for deformities, spondylolisthesis, and trauma, but not for disc degenerative disease. We really don't have any experience. But some people have had this experience in European countries, and they found it very expensive and quite dangerous, as you can see here. Another very good thing that Illizarov method and Illizarov devices can be very, very handy research tools. So you can use Illizarov frames on animals and make very good investigations because you can control the process, you can control the fusion, you can test different kinds of bone. So you can do anything using Illizarov external frames. For example, this is a very simple model which I made by myself. So it is absolutely cheap and effective. So it's external fixation and you need only a plastic tube and you need 2 ordinary injection needles to make an experiment. So it's a very good choice for making research. Another thing that you can make movements research in, of course, not in live people. So it's a very handy research tool. Then we'll speak about types of modern external spine fixation. Only 2 types are available now. It's real spine fixator or transpedicular fixation when you are going directly to spine. And it's hollow systems, different kinds of. So talking about transpedicular system, you will see it later. So it's very simple set with about not more than 30 details. So you can do with it anything if you will add some details from ordinary Illizarov set. So you can combine ordinary Illizarov with these details and do anything you want. I will show you now. So as usually, we make transpedicular fixation using C-arm because you must be absolutely sure that you are in the right place, that you are in the pedicula of vertebra, because you make all these things percutaneously in a closed procedure. So you must be sure. Then you can make different constructs using different details of illizarov frames to make to take away deformity, for example, like like here in all planes. So you really can restore the normal alignment of spine as you like, using step-by-step, clinically controlled external fixation, like this in scoliosis deformity. Another type is hollow. So hollow, we usually use this 4-pin standard corona, and you can fix this corona to pelvic ring. So it is usually made from illizarov details tour, and it's very simple and very quick method. So it usually takes about half an hour, 40 minutes to apply all this system, and especially it is very excellent in emergency. You can use Holocaust system without pelvic fixation. You can use this new device, so it's a hollow pneumatic system. We have a patent for this. So it's usually a problem when a patient is laying and you try to distract his neck. You can't make sagittal alignment. So it's very simple. You can make it from ordinary balloon from bicycle. So you can make reclination of neck in the position in which you need more. So you can really make frontal reclination in the sagittal plane for neck. So it's very simple hardware. We made it by ourselves. Another very simple thing is hollow detorsion system, and we usually use it in little children to, with Atlanta axle fixation. So it's again very cheap and easy, especially in little children, when you don't want to make a surgery treatment for them. Okay, about some cases. So you see, we use external fixation in deformities only in a very high risky situations, not in all. Frankly speaking, it's about maybe 2–3% of deformities, not more. So 98% of deformities, we don't use it at all. Only very, very hard, complex deformities. For example, here we are afraid of problems in the canal, because here you see neurofibromatosis, and there is a big neurofibroma in the canal. So we use it to test the situation before we can apply internal fixation. Or in rigid kyphosis, because they usually have some problems with neurological deficit. Even if you are using electromonitoring and if you are using wake-up test, you can catch some problems after surgery anyway. In complicated spondylolisthesis, where it's very rigid, where it's very huge dislocation of L5 or L4, so you can use it before as a first stage, as a traction stage, and then anyway you will go to internal fixation and fusion. Of course, it may be hollow systems if you have very acute and very hard conditions, like you see here in Lier disease, when you need a hollow pelvic fixation to get this boy some air to his lungs, because he really couldn't breathe because of deformity. So he got in emergency to a hospital, regional hospital, children's, not to our hospital. And then we got there and applied at first this system. Then we restore the right position of his neck. And then we go to internal fixation. Of course, X-Fix is excellent in septic conditions, when you can't stay with the hardware inside a person, where it is a real septic condition around your implants, and you can't do anything when you have a big bad sore or you have a very bad wound. So you need to use some external fixation and to fix the problem, like here. So you can use only external fixation to wait for fusion. And of course, it's really a safe boat when you see conditions like this, 2 years child with a big bed sore. In his kyphosis, he has abnormality, and Sergey will tell you a little bit more about this here in his next lecture. So you see that we have steps, and we got external frame, like big illizarov frame, on his body. So and it took only 1 month to close this big wound, this big bed sore, without any plastic. And previous surgery, surgeons worked with him for 1 year to close this bed sore with no success. Because what is ideal in Illizarov is making condition for closing all these problems with soft tissue. So we create great conditions for spine to close this bed sore, and it works very quickly. I will show you then another case, and this girl is now laying in our hospital. So before going here, we apply the system, and then we will come back, and next week we will make the additional surgical internal treatment for her. But we really couldn't do this at first, because you see, there is a great kyphosis. She's of course paraplegic, but there is a great bed sore, and we really couldn't close it. And we really couldn't go to internal fixation, to vertebrotomy, to make her spine straight, to make her sit, because of this bad condition of her soft tissue. So we apply this system. It's a transpedicular and pelvic system, you see, very simple, and create the best conditions to close this bed sore. So you see the dates. Yes, it's 6th of November. After only 6 days, 1 week, sorry, after 1 week, you see good granulation around the wound. And only 20 days after. So it was before our going to India. So no bed sore, only for 20 days, without any plastic. So now we can come back and make a big surgical procedure on her. Shortening procedure and fixation with internal devices. But it makes possible to do this. So it's a real safe boat in spine surgery in these hard conditions. So the key points are, as you see, that external fixation is a very handy research tool. But the main indications for external spine fixation is high risky spine surgery. Use external fixation temporarily and be quick to replace it with internal fixation. It is excellent in septic conditions, and only hollow can be used alone in some pediatric cervical conditions. So don't be afraid to combine. Spine surgery is a very big field in modern neurosurgery and orthopedics. But if you are free with Illizarov techniques, if you understand what you can do, you are absolutely safe. You have a safe boat, and you have a very good research hardware. So once again, I will tell you about our journal. It's Asami Russia Journal, and we'll be happy to see your publications. You can send them in English. And we have a lot of training courses and master classes. And of course, we'll be happy to see you in AOLF. It's a francophonic organization. The first meeting will be of AOLF not in francophonic country. Russia is not francophonic country. We speak Russian, but our center organize this meeting in St. Petersburg. And one day will be the satellite meeting for Asami Russia. So we will be happy to see you all, because it will be an excellent lectures on this one-day Asami satellite. And St. Petersburg is very beautiful, as you know. So it will be in May, and we will be happy to see you there. And of course, maybe we'll make a very good promotion for our Goa meeting in September in India, on this meeting in St. Petersburg.